The management of colon cancer, a modern multidisciplinary perspective. Hello and welcome to today's discussion on the comprehensive management of colon cancer. Today, we'll explore how modern medicine approaches this disease, using a multidisciplinary strategy that brings together a variety of specialists. Our aim is to present a clear, structured overview, similar to how we might discuss breast cancer, but with a focus on colon cancer. Introduction. Managing colon cancer involves a highly organized process. The central pillar for treating localized disease is surgical removal of the cancer, while systemic therapies are reserved for advanced cases. The most important factor in determining treatment is the pathological stage of the cancer, as this provides critical information about prognosis. The core team involved in care includes colorectal surgeons, medical oncologists, radiation oncologists, though their role is more significant in rectal cancer than colon cancer, gastroenterologists, radiologists, and pathologists. There are several overarching goals in the treatment of colon cancer, achieving cure for patients with localized and some limited metastatic disease, ensuring complete removal of the primary tumor and any affected lymph nodes, preventing recurrence through additional therapies administered after surgery, providing relief of symptoms and extending survival for those with incurable metastatic cancer. The foundation, diagnosis and staging. Before beginning treatment, it is essential to gather thorough information. Diagnosis typically starts with a colonoscopy and biopsy, which almost always confirms adenocarcinoma. The tumor's grade is assessed to determine whether it is well, moderately, or poorly differentiated, and the presence of invasion into lymphatic or blood vessels indicates a higher risk of spread. Molecular and biomarker testing has now become standard practice, especially for advanced disease. This includes assessing the status of mismatch repair and microsatellite instability, which can guide immunotherapy decisions. Testing for specific gene mutations, such as those in RAS and BRAF, is crucial for predicting whether targeted therapies will be effective. The status of human epidermal growth factor receptor 2 is also an emerging area of interest in metastatic disease. Staging of the cancer is conducted using the tumor node metastasis system, which outlines the extent of disease spread. Imaging techniques, such as computed tomography scans of the chest, abdomen, and pelvis, are standard for determining how far the disease has progressed. Blood tests for carcinoembryonic antigen are used to monitor response to treatment and recurrence. Treatment modalities. The toolkit. Local therapy. Surgery. Surgical treatment is the cornerstone of cure for patients without metastatic spread. The procedure typically involves removing the segment of the colon that contains the tumor, along with its blood supply and lymphatic drainage. This can be achieved through minimally invasive techniques or traditional open surgery. The goal is a complete removal, with no residual cancer cells left behind. It is important that at least 12 lymph nodes are examined to ensure accurate staging. In cases where the cancer causes obstruction or perforation, emergency surgery may be required, which is associated with higher complication rates. Systemic therapy. The choice of systemic treatment, whether chemotherapy, targeted therapy, or immunotherapy, depends on the stage and molecular features of the tumor. Chemotherapy regimens center around drugs that disrupt the growth of cancer cells, such as fluorouracil or its oral counterpart, capecitabine. These are often combined with other agents, including oxaliplatin and irinotecan, to increase effectiveness, especially in metastatic cases. Targeted therapies are used primarily when the cancer has spread. Agents that block the formation of new blood vessels, such as bevacizumab and other similar drugs, help starve the tumor. In certain cases, drugs that target the epidermal growth factor receptor, such as cetuximab and panitumumab, are effective, particularly when the tumor lacks mutations in the RAS and BRAF genes. Immunotherapy has emerged as a powerful tool, especially for tumors with deficient mismatch repair or high microsatellite instability. Medications such as pembrolizumab and nivolumab have shown remarkable results in these cases, and are now also being used before surgery in select patients. Putting it all together, stage-based management. Let us review how treatment is tailored according to the stage of the cancer. For stage 1, where the cancer invades only the early layers of the colon and has not reached the lymph nodes, surgery alone cures more than 90% of patients. No further therapy is usually required. Stage 2 cancers penetrate deeper into the colon wall or surrounding structures, but still do not involve lymph nodes. This group varies significantly, so management is more nuanced. For those with low-risk features, such as minimal invasion and no concerning pathology, observation or single-drug chemotherapy may be considered. For higher-risk cases, such as those with poor differentiation, vessel invasion, perforation, or inadequate lymph node assessment, combination chemotherapy is often recommended, after discussing the potential risks and benefits. Notably, patients whose tumors display deficient mismatch repair or high microsatellite instability tend to have an excellent prognosis and may not benefit from standard chemotherapy, so surgery alone is often sufficient. Stage 3 involves any depth of invasion along with lymph node involvement. Here, the standard approach is to use combination chemotherapy for about 6 months. The specific regimen is chosen based on the patient's overall health and risk profile. In lower-risk stage 3 cases, a shorter duration of therapy may be just as effective as longer treatment. For higher-risk disease, a full 6-month course is preferred. Stage 4 is characterized by distant metastases. Management becomes highly personalized at this point. First, the team determines whether cure is possible, which depends on whether the metastases can be surgically removed. If so, the approach is to resect both the primary and metastatic sites, often with chemotherapy given before or after surgery. When cure is not possible, the goal shifts to controlling disease and alleviating symptoms. Systemic therapies are chosen according to molecular markers, with different combinations for those with wild-type genes, specific mutations, or particular biomarker profiles. For tumors with deficient mismatch repair or high microsatellite instability, immunotherapy is now the standard first-line approach. Patients with amplification of human epidermal growth factor receptor may second benefit from targeted anti-human epidermal growth factor regimens. Special considerations and survivorship. Radiation therapy has a limited role in colon cancer and is used mainly for symptom relief in cases of metastatic spread to bone or brain, or for locally unresectable disease. After successful treatment, patients enter a surveillance program designed to detect recurrence or new growths. This involves regular checkups, blood tests for carcinoembryonic antigen, periodic computed tomography scans for 3 to 5 years, and colonoscopy 1 year after surgery and at regular intervals thereafter. A diagnosis of Lynch syndrome, also known as hereditary nonpolyposis colorectal cancer, is suspected when tumors display mismatch repair deficiency, especially in younger patients or those with a strong family history. Referral for genetic counseling is essential in these cases. Conclusion: the management of colon cancer has evolved from a uniform approach to one driven by precision medicine. While surgical removal remains the primary method for curing localized disease, decisions regarding additional therapy and choices for treating metastatic disease are now guided by pathological staging and molecular biomarkers. This personalized strategy has significantly improved outcomes, particularly for those facing advanced disease. Thank you for joining today's discussion, and we hope this overview has provided valuable insights into the modern management of colon cancer. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.